Dr. Charisma to start the presentation. Please go ahead.
Good morning, everyone. My name Good morning, everyone. My name is Dr. S.
Charishma, slide share mode pettu.
My topic is traumatic brain injury. My moderator is Dr. D. Lakshmi Rani, who is the HOD of Critical Care Medicine in Care Hospitals, Visakhapatnam.
హలో చరిష్మా వినపడట్లేదు.
స్లైడ్స్ మూవ్ అవట్లేదా?
హలో
స్లైడ్స్ మూవ్ అవట్లేదా? రెండు మూడు సార్లు క్లిక్ చేయండి, మూవ్ అవుతాయి. కొంచెం స్ట్రక్ అవుతుంది ఒక్కోసారి. ట్యాప్ ఇట్ 2-3 times and then move చేయి.
Yes, sir. Today I'm going to discuss about the causes of traumatic brain injury, pathophysiology, assessment, initial and secondary assessment, management goals in traumatic brain injury, and the prognostic features. Traumatic brain injury is the leading cause of mortality and morbidity in children and young adults in both developed and developing nations. It is an acute brain injury arising.
చరిష్మా స్లైడ్స్ మూవ్ అవ్వట్లేదు. అక్కడ ఏడిపి అబ్బాయి ఉన్నాడు, అడుగు.
PPT workout.
చరిష్మా మూవ్ అయినట్టుంది, నెక్స్ట్ కెళ్ళు.
అది స్లైడ్ షేర్ ఒకటి వర్క్ అవ్వట్లేదు మ్యామ్. పవర్ పాయింట్ వర్క్ అవ్వట్లేదు మ్యామ్. వితౌట్ అయితే వర్క్
అక్కడ అబ్బాయి ఈడిపి అబ్బాయి లేడా?
ఇలాగే అవుతుంది మ్యామ్. ఇది ఫుల్ స్క్రీన్ చేస్తే అవ్వట్లేదు మ్యామ్.
సరే, ఇలాగే నెక్స్ట్ స్లైడ్ కి వెళ్ళిపోండి.
ఫిజికల్ డిస్టెన్స్ కొన్ని స్టాక్ పెట్టుకున్నాము. మేడం అది బయట పంపించేటప్పుడు వాళ్ళు కొందరు అడుగుతున్నారు పైకి వాళ్ళు.
కంటిన్యూ చేయమ్మా, ఇంకా టైం అవుతుంది.
The contents
ఇలాగే వెళ్ళు.
today's discussion are causes of traumatic brain injury, pathophysiology, initial assessment, secondary assessment, management goals in traumatic brain injury, and prognosis. Traumatic brain injury is the leading cause of mortality and morbidity in children and young adults in both developed and developing nations. It is an acute brain injury arising from mechanical injury to head from external physical forces. It is an alteration in brain function or evidence of brain pathology caused by an external force. The leading causes of traumatic brain injury are falls and motor vehicle accidents and assaults. Other causes include suicide and some transport injuries. To identify clinically whether the patient is having traumatic brain injury, there should be one or more of the following. There should be confusion or disorientation, loss of consciousness, history of post-traumatic amnesia, and other neurological abnormalities like seizures or focal neurological signs or intracranial lesions. The pathophysiology includes trauma to the head causes a primary injury which results in skull fracture or cerebral contusion, hemorrhage, which is due to a direct physical consequence of the impact. Hours or days later, there will be secondary injury which determines the patient's ultimate neurological outcome. Injury to the brain is caused by external forces which can be classified as contact or inertial. Contact forces produce skull fractures, contusions, and hematoma, whereas inertial forces result from brain undergoing acceleration or deceleration and can occur without head impact. So primary injury is dealt to the brain directly due to initial insult, whereas secondary injury is due to hypotension, hypoxia, hemorrhage, intracranial hypertension, cerebral edema, seizures, and metabolic derangement. This is a tabular view of pathophysiology. Because of damage to the brain, there will be damage to the blood vessels which open the blood-brain barrier, which increases the interstitial fluid and tissue pressure, which results in vasogenic edema. And there is also a cell death because of activation of biomolecular mediators of injury, which results in neuronal damage and cytotoxic edema. Decrease in cerebral perfusion pressure leads to vasodilatation, which causes increased cerebral blood flow. Cerebral perfusion pressure, which decreases, also increases the intracranial pressure to increase the cerebral blood flow. These changes result in secondary brain injury. The types of traumatic brain injury include extraaxial lesions and intraaxial lesions. Extraaxial lesions are the skull fractures, epidural, subdural, subarachnoid, and intraventricular hemorrhage, whereas the intraaxial lesions are hemorrhagic and non-hemorrhagic contusions, parenchymal hematomas, and diffuse axonal injuries. Skull fractures are linear fractures, depressed fractures, and basilar fractures. Subdural hematoma is most commonly seen around 20 to 25%, and it develops between the surface of the brain and inner surface of the dura and is believed to result from tearing of the bridging veins. Epidural hematoma is developed between the inner table of skull and dura, and usually where the middle meningeal artery or one of its branch is torn by skull fracture. Subarachnoid hemorrhage is result from the tearing of corticomeningeal vessels, and they don't usually produce any hematoma or mass effect. Intraparenchymal hematoma is hemorrhage within the brain substance that occurs after traumatic brain injury. It is thought to be resulted from disruption of perforating arteries at the time of uncal herniation. Contusions are heterogeneous lesions comprising of punctate hemorrhage and necrosis. Depending on the size and location, they may cause mass effect. Diffuse axonal injury refers to a laceration or punctate contusions at interface between gray and white matter. Primary survey. Whenever a patient comes, initially we have to do a systematic approach to assess and treat the patient. Initial assessment of airway and C-spine motion restriction, breathing and ventilation, circulation, hemorrhage control. D is disability or neurological assessment. E is exposure and environmental control. A basic neurological assessment of AVPU, which is A stands for alert, V verbal response, P response to painful stimulus, and U is unresponsiveness, should be performed. And his ample history, which is history of allergies, medication, past medical history, last meal, events surrounding injury and environment should be taken. Physical examination should be done. Later, after the initial examination, a detailed neurological examination should be done, which includes assessment of the Glasgow Coma Scale or 4 score, and pupil size and reaction, level of spinal cord injury, cranial nerves examination, fundoscopic examination, and motor examination. The Glasgow Coma Scale involves three features. One is the eye opening, verbal response, and motor response. Motor response, 6 is obeying commands completely, 5 is localizing to stimulus, 4 is normal flexion, 3 is abnormal flexion, 2 is extensor response, 1 is no response. Verbal response is 5 is patient is oriented, 4 patient is confused, 3 patient is able to mutter words, 2 patient is 1 is no sounds. Eye opening, 4 is spontaneous eye opening, 3 is opening to speech, 2 is opening to pain, and 1 is no opening. GCS score is about 15, and based on the Glasgow score, we can divide the traumatic brain injury into mild, moderate, and severe. 4 score is full outline of unresponsiveness score. It includes eye response, motor response, brainstem reflex, and respiration. In eye response, patient number 4 is eyelids are open and tracking. Number 3 is patient's eyelids are open but not tracking. 2, eyelids are open but opens to loud voice. Number 1 is patient's eyelids are closed but opening to pain. And number 0, patient's eyelids remain closed with pain. Motor response, patient is able to make a fist sign. 3 is localizing to pain. 2 is flexion response to pain. 1 is extensor response. 0 is no response or status epilepticus. Brainstem reflexes, level number 4 is pupil and corneal reflexes both are present. Number 3, one pupil is wide and fixed. Number 2, pupil or corneal reflexes are absent. 1, pupil and corneal reflexes both are absent. Grade 0, absence of pupil, corneal, and cough reflexes. Respiration, patient is not intubated and regular breathing is 4. Number 3, patient is not intubated and there is abnormal shallow respiratory breathing like chain stroke breathing pattern. Number 2, patient is not intubated, irregular breathing pattern. 1, patient breathes above ventilatory rate, and 0, patient breathes at ventilatory rate or apnea. 4 scale has better predictive power for mortality and may be more suitable alternative or complementary tools for GCS. After the initial neurological evaluation and stabilization, radiological evaluation with CT scan is performed to diagnose the underlying disease process. Indications for CT scan is it should be carried out in all moderate to severe traumatic brain injuries. Whenever there is mild traumatic brain injury, indications are open or depressed skull fractures, signs of basilar skull fracture, vomiting more than 2 episodes, age is more than 65, anticoagulant use, post-traumatic seizures, GCS less than 12 at the time of initial assessment or less than 15 at 2 hours after injury on assessment in ER, retrograde amnesia more than 30 minutes, dangerous mechanism of injury like fall from a height or direct collision with a motor vehicle or multiple fractures. Once the indications for intubation, we should intubate and ventilate the patient immediately to 8. Whenever there is loss of protective laryngeal reflexes or hypoxemia where PaO2 less than 97 mm of mercury of oxygen, hypercarbia where PaCO2 is more than 45 mm of mercury, spontaneous hyperventilation causing PaCO2 less than 30 mm mercury, and irregular respirations. Part of journey if there is any unstable fractures of facial skeleton and copious bleeding in the mouth and seizures. In treatment, tier 0, tier 1, tier 2, and tier 3 management are present, where tier 0 is ICU admission, intubation, and mechanical ventilation, and central and arterial line insertion, and monitoring of ETCO2, ICP monitoring, analgesia sedation for comfort, mechanical ventilation, avoidance of pyrexia and hyponatremia, SpO2 more than 94%, CPP is cerebral perfusion pressure more than 60 mm mercury. Hemoglobin should be more than 7 grams per deciliter and consider anti-epileptic CPP is 60 to 70 mm Hg. Analgesia and sedation for ICP control. PaCO2 35 to 38 mm Hg. Bolus hyperosmolar therapy with mannitol hypertonic saline up to sodium levels of 130, 155 or serum osmolarity 320 milliequivalents per liter. CSF drainage by extraventricular drainage, and consider anti-seizure prophylaxis and EEG monitoring. Tier 2 therapy includes mild hypocapnia where PaCO2 is 32 to 35 mm mercury. Consider trial dose of neuromuscular blockade if effective with continuous infusion. Ensure adequate sedation. Assessment of cerebral autoregulation where MAP challenge and CPP should be adjusted. Tier 3 therapy are barbiturate coma, mild hypothermia 35 to 36 degrees centigrade, and secondary decompressive craniectomy. Management of traumatic brain score, according to Brain Trauma Foundation 4th edition, there are three major goals where thresholds, monitoring, and treatment modality are taken. Thresholds include thresholds for blood pressure, intracranial pressure, cerebral perfusion pressure, advanced cerebral monitoring. And monitoring includes the intracranial pressure monitoring, cerebral perfusion pressure monitoring, and advanced cerebral monitoring. The treatments include decompressive craniectomy, prophylactic hypothermia, hyperosmolar therapy, CSF drainage, ventilatory therapies, anesthetics, analgesics and sedatives, steroids, nutrition, infective prophylaxis, DVT therapy, deep vein thrombosis prophylaxis, and seizure prophylaxis. In thresholds, there are level 3 recommendations of maintaining systolic blood pressure more than 100 mm mercury for patients above 50 to 69 years and at more than 110 millimeters of mercury over 70 years. Mean arterial blood pressure should be maintained at a higher level at about 85 to 110 millimeters of mercury to improve outcomes. And IC intracranial pressure, if it is more than 22 mm mercury, it is a level 2B recommendation, and values above this are detrimental to good outcomes, and they are associated with increased target cerebral perfusion pressure is between 60 to 70 mm mercury, and it should not fall below 50 mm mercury or above 70 mm mercury, which for good outcomes, and it is a level 2B recommendation. Jugular venous saturation should not be less than 50% saturation to improve outcomes, which is a level 3 recommendation. And brain tissue oxygen monitoring should be less than 20 millimeters mercury. Monitoring, ICP monitoring should be done in severe traumatic brain injury as a level 2B recommendation to reduce 2-week post-injury mortality. Cerebral perfusion monitoring in management of severe traumatic brain injury is a level 2B monitoring to decrease 2-week mortality, and level 3 recommendation of brain tissue oxygen monitoring is removed due to contradictory evidence. Decompressive craniectomy. These are the definitive treatment modalities. In decompressive craniectomy, there is level 2A evidence of bifrontal decompressive craniectomy. It is not recommended to improve the 6 months post injury in severe traumatic brain patients, but it is used to demonstrate to reduce ICP and to minimize days in intensive care units. And prophylactic hypothermia, whether early within 2.5 hours of insult or short term with 48 hours post injury, is not recommended to improve outcomes in patients with diffuse injury. Although hyperosmolar therapy may lower the ICP, there was insufficient evidence about its effect on clinical outcomes to support its use in traumatic brain injury. CSF drainage, there is an EVD, extraventricular drain is placed at the level of midbrain with continuous CSF, which is considered to lower ICP than an intermittent use. CSF drainage with initial Glasgow coma score less than 6 during first 12 hours after injury may be considered as a level 3 recommendation. Prolonged prophylactic hyperventilation with arterial PCO2s less than 25 mm mercury is not recommended, which is a level 2. Of barbiturates to induce burst suppression in EEG as prophylaxis against development of intracranial hypertension is not recommended, whereas high dose of barbiturates is recommended to control raised ICP refractory to maximum standard medical and surgical treatment. Steroid use is not recommended for improving outcomes or reducing ICPs. Feeding patient to attain basic caloric replacement at least by 5th day is recommended to decrease mortality. Transgastric jejunal feeding is recommended to reduce incidence of ventilator-associated pneumonia. Early tracheostomy is recommended to reduce mechanical ventilatory days. Use of povidone iodine oral care is not recommended to reduce ventilator-associated pneumonia and may increase the risk of acute respiratory distress syndrome. Antibiotic impregnated catheters may be considered to prevent infections during EVDs. Low molecular weight heparin may be used in combination with mechanical prophylaxis as a level 3 recommendation. However, there is an increased risk of expansion of intracranial hemorrhage. Prophylactic use of phenytoin or valproate is not recommended to prevent late post-traumatic seizures, which are seizures which are presented after 7 days of injury, whereas phenytoin is recommended to decrease. Yes, sir. Phenytoin is recommended to decrease incidence of early post-traumatic seizures which occur within 7 days of injury. The grading of severity of traumatic brain injury. Severity of injury is graded as mild, moderate, or severe. Mild injury, where a Glasgow coma scale is about 13 to 15, and duration of loss of consciousness is up to 0 to 30 minutes, and duration of post-traumatic amnesia is less than 24 hours. Moderate traumatic brain injury, where Glasgow coma scale is 9 to 12, duration of loss of consciousness is 30 minutes to 24 hours, and duration of post-traumatic amnesia is 1 to 7 days. Severe traumatic brain injury, where Glasgow coma scale is 3 to 8, loss of consciousness is more than 24 hours, and duration of post-traumatic amnesia is more than 7 days. The complications of traumatic brain injury are trauma-induced coagulopathy, acute respiratory distress syndrome or negative pressure pulmonary edema, paroxysmal sympathetic hyperactivity, stress cardiomyopathy, hypothalamic adrenal dysfunction or SIDH, or cerebral salt wasting, hydrocephalus and heterotropic ossification, spasticity, chronic traumatic encephalopathy or post-traumatic headache and depression, gastrointestinal gastrourinary complication, gastric ulcers, and deep vein thrombosis. Prognosis. Prognosis is very difficult and complex in traumatic brain injury patients. There will be individual risk factors for poor outcome, and usually low GCS, especially the motor score, is a very poor prognosis. Increasing age, bilateral absence of pupillary light reflex, associated injuries, abnormal CT at the time of presentation of injury, hypotension, hypoxemia, elevated intracranial pressure or reduced cerebral perfusion pressure, bleeding diastasis and pyrexia are very poor prognostic indicators for traumatic brain injury. CT findings associated with poor prognosis are absence or compressed basal systems, traumatic SAH, presence and degree of midline shift, and presence of abnormalities in initial CT. Rotterdam CT score is a simple method for scoring the initial non-contrast CT in traumatic brain injury that can be used to predict a mortality. Glasgow outcome score or GAU score is score 1 is death of the patient, and score 2 vegetative state, score 3 lower severe disability, score 4 upper severe disability, 5 lower moderate disability, 6 upper moderate disability, 7 lower good recovery, and 8 upper good recovery. Thank you.
స్లైడ్స్ ఫుల్ స్క్రీన్ రాలేదమ్మా.
సార్ అది షేర్ అవ్వట్లేదు, ఫుల్ స్క్రీన్ చేస్తుంటే మూవ్ అవ్వట్లేదు సార్.
నువ్వు కొంచెం పెద్దగా మాట్లాడు, కొంచెం దగ్గర మైక్ దగ్గరకు వచ్చి, అది వినిపించట్లేదు.
ఫుల్ స్క్రీన్ చేస్తుంటే మూవ్ అవ్వట్లేదు సార్.
ఓకే, థ్యాంక్ యూ చరిష్మా. వెరీ క్రిస్ప్ short presentation, but it is nice presentation. Any questions?
Karishma, out of recommendations, any class 1 recommendation?
Generally, there are only class 2 recommendations and class 3 recommendations, ma'am. Class 1 recommendations, there are no in this recent edition, there is no class 1 recommendations right now, ma'am. Any changes?
మోడరేటర్ ఎవరు దీనికి?
మోడరేటర్ రాణి మేడం సార్.
సార్
రాణి మేడం మోడరేటర్.
ఓకే.
Chirishma, how do you differentiate SADH and cerebral salt wasting syndrome?
In SIADH, there will be overactivity of antidiuretic hormones, sir. So there will be urine osmolarity will be high, sir, and serum sodium levels will be urine and sodium levels are high, sir, and decreased cerebral sodium levels. In SIADH, there will be euvolemia to hypervolemia, sir, whereas cerebral salt wasting patient may be in hypovolemic conditions.
Serum uric acid is the differentiating factor. In both the conditions, hyponatremia will be there. As you said, the dehydration will be there in CSW, whereas euvolemic or hypervolemic in SADH, and uric acid high in CSW, whereas it is normal or normal in SADH. So CSW hyperuricemia, whereas SADH normal uric acid.
Yes, sir.
Ma,
Yes, sir.
please ask questions, sir. It is a big topic.
Anuradha, on the we should make sure that all the students should attend, kada. Mohan Rao, Ram Naidu, and Anuradha.
తక్కువ మంది అటెండ్ అయ్యారేంటి?
అదే సార్ నేను ఆలోచిస్తున్నాను
ఏం ఆలోచిస్తున్నారు?
ఏం చేస్తే బాగుంటదని.
అటెండెన్స్ పెంచడానికా? మధ్యాహ్నం భోజన పథకం పెడదాం.
And
లేకపోతే అటెండ్ అవ్వలేని వాళ్ళకి నెక్స్ట్ వీక్ క్లాస్ వాళ్ళకే చెప్తే వాళ్ళు చెప్తుంటే
రాదు.
ఆ?
లేదు సార్, మనం
అది అది కరెక్ట్ మోహన్ రావు గారు. అటెండ్ అవ్వడం వాళ్ళని లిస్ట్ చేసి వాళ్ళకి వరుసగా వాళ్ళ క్లాసులు వేస్తామంటే తప్పకుండా అటెండ్ అవుతారు.
అదే ఐఎమ్ యాక్చువల్లీ వెరీ డిసప్పాయింటెడ్. అవర్ స్టూడెంట్స్ ఆల్సో నాట్ అటెండెడ్.
అలా కాదు, మనకు మోటార్ పార్టీ అసలు డబ్బులు లేవు. కలెక్ట్ 1000 rupees and have this.
ఏం సార్ వద్దులేండి సార్, ఇది బాగుంది. మేడం కూడా చెప్పినట్లు
Yeah, that's good.
క్లాస్
Whoever is not attended, their class is next.
నెక్స్ట్. చరిష్మా,
Yes, sir.
అమ్మా మీరు క్లాస్ బాగానే ఉంది, ఇట్స్ వెరీ గుడ్. అంటే హౌ యూ ప్రిపేర్డ్ ఫర్ దిస్ క్లాస్? అంటే యూ టుక్ ఎనీ ఆర్టికల్, రీసెంట్ ఆర్టికల్ ఆర్ ఎనీథింగ్?
ఆ పవర్ పాయింట్ మీరు చేశారా, డౌన్లోడ్ చేశారా, లేకపోతే తయారు చేశారా?
నేను చేశాను సార్.
అదే, సో ఫర్ దట్ ఎనీ ఆర్టికల్ డిడ్ యూ డౌన్లోడెడ్ ఎనీథింగ్?
బ్రెయిన్ ట్రామా ఫౌండేషన్ అండ్ కోఆపరేషన్ నైస్ గైడ్ లైన్స్ కొన్ని చూసాను సార్. తర్వాత ఇర్విన్ టెక్స్ట్ బుక్.
ఏం టెక్స్ట్ బుక్ మా?
ఇర్విన్ టెక్స్ట్ బుక్ సార్.
వాయిస్ వినపట్లేదమ్మా.
ఇర్విన్ సార్, రిప్లీ అండ్ ఇర్విన్ టెక్స్ట్ బుక్.
Okay. Did you mention about that any modified Marshall CT score grading, madam?
రోటర్డామ్ క్రైటీరియా చెప్పాను సార్, మోడిఫైడ్ మార్షల్ చెప్పాను.
ఏమి వై? అలాగే ట్రయల్స్ కూడా ఉంటాయి కదా, ఇంపార్టెంట్ ట్రయల్స్, యూ విల్ గెట్ క్వశ్చన్స్ కదా అని యువర్ థియరీ ఎగ్జామ్. And you especially mentioned about frontotemporal decompressed craniotomy kada. So what controversies? You have to go in depth. But nice presentation. What is the indication for the anti-seizure prediction?
For post-traumatic seizure, early presentation, sir, within 7 days, use of phenytoin is recommended, sir. Or if it is more than after 7 days, late presentation, use of prophylactic anti-seizures medication like phenytoin or valproate is not recommended, sir.
Any other indication during head injury?
Seizure prophylaxis. Sir.
డిప్రెస్డ్ స్కల్ ఫ్రాక్చర్ అన్ని ఉన్నాయి కదమ్మా, 7-8 ఇండికేషన్స్ ఉన్నాయి కదా.
అది
బేసల్ స్కల్ ఫ్రాక్చర్.
బేసల్ గా డిప్రెస్డ్ ఫ్రాక్చర్ అమ్మా సార్ చెప్పినట్లు.
ఫ్రాక్చర్, GCS less than 8, న్యూ డెవలప్మెంట్ ఆఫ్ ఫోకల్ న్యూరలాజికల్ డెఫిషిట్. ఇండికేషన్స్ ఫర్ సీజర్ ప్రొఫిలాక్సిస్ ఇన్ TBI.
What is the indication for mannitol, or you will routinely give all head injury patients?
Mannitol is used. Mannitol is used for decreasing raised intracranial pressure, sir. But there is no recommendation for improving outcomes, sir. Patient is in mannitol should be given in without any. Patient doesn't have any history of any cardiac history or any acute kidney injury, and euvolemic state, patient can be given with mannitol. So hemodynamics are good, mannitol can be given to reduce the raised intracranial pressure, sir.
Mannitol versus 3% saline, which is better? Any recommendation or guideline?
Both guidelines.
Is there any relation between the
స్టడీస్ ఏమన్నా చదివావా?
anytime 3% saline scores better over mannitol? Can you hear me, anybody? I'm sorry.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Any relation between serum osmolarity and raised ICP with therapeutic measures?
When patient is having or decreased in hypovolemic states, 3% saline can be given, sir.
Any recommendation, references?
Freshly passed out, Trupti will tell.
Sir, as of now, what I read is there is no superiority of one over the other. But in renal failure, acute renal failure, 3% NaCl is preferred over mannitol.
Is it only 3% studied or any other thing studied?
Sir, I am only aware of this one, sir.
There
But,
is
one-
studies are
no
studies
one
are
is
being done on
superior.
high concentration, not 3% saline.
Okay,
3%
sir.
saline is available in India. That's why we attribute the same to 3% saline. But studies mannitol
sir.
versus it's not 3% saline. No, it is hypertonic saline.
Yes,
And that
sir.
hypertonicity is not 3%.
Yes, sir. 23 point.
How do you administer mannitol?
We have to administer mannitol 0.25 to 1 mg per kg body weight, sir, and see the urine osmolality.
It's over 24 hours, Amma.
6th hourly, sir. 6th hourly. We have to administer.
Any recommendation?
Sir, urine osmolality, if it reaches 320 milliosmoles, we have to stop administering mannitol.
Duration of administration?
Duration, I'm not sure, sir. 5
It should be
days.
given as rapid as possible. You have to suddenly create a drift of
Okay.
osmolarity.
Okay, sir.
If you give slowly, drop by drop, it won't work. The purpose is not served.
Okay, sir. Okay, sir. Thank you, sir.
Lot more things to be discussed, Amma. I don't know.
Yes, sir.
Charishma, any crash?
Please discuss, Satish, nothing wrong. We are here to discuss, still we have time. Satish, sir,
Sir.
please discuss.
So all the things, sir, whatever we discussed, see, prophylactic, anti-epileptic and traumatic brain injury, one point of discussion. Second thing is mannitol versus 3% saline. Two are important. Then monitoring with intracranial pressure, invasive versus non-invasive, which is better. And craniotomy, emergency, bitemporal, bitrompo, frontotemporal, parietal craniotomy versus conservative management. So there is an Australian ANGIC study clearly showed that there is some help if it is an extensive craniotomy done bilateral. Otherwise, there is no role. Second thing is invasive versus routine clinical evaluation of GCS pupillary reflexes. Invasive does not have any advantage over routine clinical examination and follow-up of the neurological assessment. Prophylactic anti-epileptic is clearly there is 4 or 5 indications. One few I remember is depressed skull fracture, large area of infarct, intraventricular bleed. All these things require prophylactic anti-epileptic. 3% saline versus mannitol. Nothing is superior to other. Both are equally good efficacy wise, but side effects wise, mannitol is more prone for renal shutdown. So 3% saline is preferred over mannitol, but we have to give a bolus dose and create a sudden drift of osmolarity, then maintain it. This is what I can tell from my side. Any seniors can add?
Charishma, how will you diagnose diffuse axonal injury?
In CT, we can see the punctate lesions, sir. Usually it's diagnosed after brain injury with GCS less than 8 for more than 6 hours. Sir. In CT, small punctate hemorrhages to white matter can be indicative of diffuse axonal injury. Sir.
But it's always not, we can't appreciate kadamma punctate lesions CT scan lo. most of them, what happens, patient GCS will be low, but there will be CT scan grossly appears normal. What do you say, intraventricular hemorrhages or that paraventricular hemorrhages will be there. What are the indications for ICP monitoring?
GCS less than 8, sir, or worsening GCS less than initial presentation less than 12 and later over 2 hours. GCS is worsening less than 15, sir. Decrease cerebral in clinical deterioration, sir. In ophthalmic findings, any edema, sir. Increased raised mean arterial blood pressure, systolic pressures are high, sudden onset vomitings or seizure, new onset seizures, or motor posturing, any hypotension or age more than 40, sir. With a patient with abnormal head CT with edema or hematomas or compressed basal system, sir.
As far as I know, only 3 indications. One is age of more than 40, GCS less than 80, and in a diffuse axonal injury.
Yes.
You manage what is the cerebral perfusion pressure?
Cerebral perfusion pressure is difference between mean arterial pressure and intracranial pressure, sir. It should be maintained around 60 to 70 mm mercury, sir, for adequate cerebral blood flow, sir. So we have to reduce the intracranial pressure and mean arterial pressure to maintain the cerebral perfusion pressure, sir.
In the GCS, which component is very, very important?
Motor
Verbal.
component is
Why? And how much? When you suspect there is an increased ICP, how much score drops?
motor component deterioration is important for indications, sir. Score
How much motor component?
at least 1 point drop.
Okay. 1 or 2.
It's my patient, patient in ICU, neuro ICU. The GCS was around with motor is 5, and patient suddenly deteriorated and decerebrating. Peoples are dilated and sluggish reacting. And what measures you will take to reduce the ICP? Immediate rescue measures.
What measures regard, sir? What measures?
What you will do?
Immediately, if GCS is decreasing, we have to immediately assess the airway, breathing, and circulation, sir. Whenever there is decrease in evidence of hypoxemia or hypotension, we have to, if the GCS is lowering, we have to intubate the patient, sir, and maintain euvolemia, sir, and start vasopressors if needed.
No, I said the people's dilated, sluggish reacting, GCS is suddenly dropped.
Immediately we have to stabilize the patient and assess for any herniations or any herniation or raised ICP could be the chance. So immediately we have to reduce the intracranial pressure and need a immediate CT, sir.
Immediate?
Sir?
Is that immediate CPA?
CT.
CT. No, before shifting, patient is crashing.
First initially stabilize the patient, sir. There may be chance of raised intracranial pressure, sir.
Yeah. That's what I asked. What measures you will take? What rescue measures you will take to reduce the ICP before shifting to OT?
we have to use a hypertonic saline or mannitol, sir, to reduce the ICP.
Infusion
and,
or bolus?
bolus of mannitol should be given, sir.
3%?
3% should be given as an infusion, sir.
In a rescue time. We'll give infusion.
At least over 20 minutes, at least we have to give, sir. Bolus.
No, for even this also we have to give bolus only. 100 ml bolus.
Yes.
Because the patient is developing midline shift. Pupils are dilated. And patient is crashing. Before you go and do the CT and coming back, patient may go into coning also.
Yes.
So to prevent the coning, you have to do rescue ICP measures to reduce the ICP. That's what I asked. What measures you will take? One is bolus, this thing, 3% saline or mannitol. Second thing,
High dose of barbiturates in refractory medical and refractory medical raised ICP. High dose of barbiturates can be given, sir. Like midazolam high dose can be given. Adequate sedation, sir.
so immediate step. What next immediate step? Hyperventilation.
Hyperventilation to reduce
Yes,
the PSA.
only indicated in rescue measures, not routinely.
Yes, sir.
Only in case of coning. Rescue measures before shifting to OT, mannitol and hyperventilation.
Yes, sir.
At least we can reduce up to 25. But normal in head injury patient, how much PCO2 will maintain?
33 to 30, 35 to 38. Sir.
Normal, yeah, less than 40. So
Yes.
here we can come down up to 25 because there is no time. It's a rescue measure before shifting to OT. For emergency craniectomy. So what orders will you give? A patient is borderline GCS, you are in night duty, is localizing pain, E2, V2, M5. So what orders will you give to the staff?
GCS should be monitored every half an hour, sir.
Huh? Okay.
Gasco coma scale should be measured every half an hour, sir, for any deterioration, and we have to check for any raised blood pressures, mean arterial pressures, any increase in mean arterial pressures, or any headache or new onset focal lesion.
Not only GCS, pupillary reaction.
Pupillary reaction, yes.
Now to maintain the cerebral perfusion pressure, but you don't have only you have NIBP. Only monitor the cerebral perfusion pressure.
Pupillary reaction and
Huh?
mean arterial pressure, any increase in or any hypotension, there may be cerebral perfusion. Decreased.
Yeah. Decreased mean arterial pressure, that worsen the cerebral perfusion pressure.
Yes, sir.
Okay, you order given to staff that half an hourly people check on GCS monitor, but after 2 o'clock they slept. Morning 5 o'clock they call that both peoples are dilated, and patient unresponsive GCS E1, V1, M1, both peoples are dilated and not reacting. What you will do?
Immediately intubate, secure the airway, sir, and check for hypotension.
Hypotension, BP 60, 70 by 40, and the heart rate is around 40 because of raised ICP. People's dilated and fixed. What is how will you manage this patient?
Immediately secure the airway, increase the blood pressure with fluid therapy and simultaneously vasopressor should be started, and reducing the maintaining the blood pressure to more than 90 or 100 systolic blood pressure, we can start 3% hypertonic saline bolus.
These incidents are happening very frequently because of monitoring of the GCS. Midnight is becoming problem, and this type of incidents are there. Any comment on this? Any senior? Sir. Hello.
Hello, David.
Any comment on this, madam?
Yeah, many times.
Increase the level of conscious of staff of monitoring patient in the early hours, midnight to early hours. మీరేం చేస్తారు మేడం? What precautions you will take to prevent these mishaps?
ఏం చేస్తామండి, స్టాఫ్ మానిటర్ చేయమంటాము. బట్ you know, if the patient condition during the night when you are doing the rounds, if they are already bad, you get everything ready. Like if they are already intubated, okay, you keep an eye on heart rate, blood pressure, all these things they have to inform. But many times you get a call early morning that severe bradycardia, like coning picture వస్తుంది, then you have to go and do CPR. అలాగే అవుతుంది. లేదా if you are already there, so you know bradycardia, initially you see bradycardia and hypertension. That time itself, you know, they may be coning. So you inform the neurosurgeon and you check the pupils, you check the GCS, and if they want to take for any intervention, try and quickly stabilize if possible. Like usually bradycardia, if it goes like below 40, you have to do something about it. Try and increase your heart rate and stabilize, and neurosurgeon may want to do take him to theater for craniectomy or something, reduction of ICP, or like imminent coning. Or if they are not taking any active measures, then we have to try as much as we can stabilize and maintain, reduce ICP, and talk to relatives.
People are dilated and fixed. Patient is already coning, daddy, and there are the signs of no cough reflex. Then we have to start counseling the patient.
I have to counsel when they are deteriorating itself. Otherwise, they may cause real chaos.
Yes, madam. Not done, but always it is safe to do counseling when the patient GCS is low.
Hello.
No.
Karishma, last thing to add is certain things to be avoided. No, avoid hyperglycemia, avoid hypotension, like hypovolemia, avoid hyperthermia. So 6 or 5 avoidance to prevent further drop in the GCS. These all the final. Grossly, you need to look into all this. Not only pertain to brain examination. So these things are also important. Maintain normoglycemia.
Yes.
Okay. Yeah, basically
should be avoided.
You need to talk something about a non-invasive assessment of raised ICP like ONSD, the optic nerve sheath diameter. So frequent monitor that also should including the routine monitoring, because sisters will monitor that about the bradycardia, hypotension, pupillary asymmetry, drop in GCS. But doctor will also monitor with the ONSD what is the diameter change of the optic nerve sheath. So which is an early finding we can find before establishing a papilledema, which is a late sign. Okay. Right. Thank you. Thanks a lot. Bye.
Time and time. Huh? 9. Over, huh? Okay. If there are no questions, we will close the session. Thank you.
Thank you, David. Thank you, Cherry.
Thank
Thank
you,
you, David.
Cherishma, but it was a last minute preparation for her. We realized yesterday evening that it's our class. Yesterday only when we saw the group that message, we realized, and she got this guidelines. It's a guidelines of 250 pages or something. She got it, and she tried to do as much as she could, and suggested to look for some latest trials and studies. But I think she could do only this much. But actually, each measure what we are doing itself is a study, and it by itself is a one topic. So it's actually very big topic, and she just made the points. For now, like I think each one we should discuss in a class, like ICP monitoring and head injuries. That's one thing, and like that, as Dr. Satish said, it's each one is a big topic. Yeah.
So you have
thank
1
you,
month
Cherishma.
time కదా నెక్స్ట్ టైం నుంచి జరగదు మేడం.
Sorry, sir.
అంటే లాస్ట్ మినిట్ చూసారు కదా, ఈసారి నుంచి అలా ఇంకో 1 month టైం ఉంది కదా, ఈసారి నుంచి అలా జరగదు, లాస్ట్ మినిట్ చూడడం ఉండదు కదా అంటున్నా.
సార్ మౌనంగా శ్రీనివాస్ మా అకాడమిక్ ఇన్ఛార్జ్ సార్. శ్రీనివాస్ గారు కొంచెం గుర్తుపెట్టుకోండి.
Srinivas is not there.
ఓకే సరే.
Madam,
Thank you.
Thank you.
Thank you all.
Thank you, madam, for nice presentation. Thank you.